Good evening, everybody. Welcome to the unique concept of Young Guns webinar. We've seen newer talents coming up. If you've been to Neurocon, we found that there were so many people in the periphery that are actually doing fantastic work, and they were hungry to showcase their talent. So in Neurocon, we had a tremendous response for the free papers, where people from all over India, specifically in Tier 3 and Tier 4 cities, were instrumental in promoting the SFM flagship by putting up their beautiful cases. And you have to realize that the younger guns are well trained. They take beautiful images. They create a fantastic the PowerPoint, and they are fantastic in their deliveries as well. We realized that in Eurocon that this is something that we need to promote and nurture. And I should thank Dr. Alok Varshney for taking the lead here in mentoring the young talents to promote their work, to give them a platform. Um, we want younger people to come up. We want younger people to keep putting up their interesting cases. And you will realize in today's session how not only did they take beautiful images, but they actually work up the cases. They have genetics with them. So it's all in all, this is what we are looking forward to. So without much ado, I would like Dr. Alok Varshney to take this forward. Over to you, Alok.
Thank you, Mohit sir, for introducing the Young Guns concept. So let me take you through what it takes to be a young gun. All right, so I hope you can see the slide.
Yes, yes, yes.
So in 5 minutes, I'm going to tell how to be a young gun. So what are the ingredients that we need for a young gun? Is it talent? Is it hard work? Is it attention to detail? All of these. I think when you are a doctor, when you are into fetal medicine, when you're looking as a fetal imaging specialist, I think that you have reached here because you have already all of these qualities. Okay. But what we require is beautiful cases. We require cases which have good imaging, which are well worked up, which have something, some educational potential for rest of the people, rest of the masses. But where are those cases? Are they in your dusty archives, sitting in some drawer or in your hard disk somewhere? Or are you sharing them on WhatsApp where nobody is, looking at them, or maybe a few people, they are disinterestedly answering a few lines about it. But what are you learning from? Okay, so do not hoard your cases. This is my request. You need to show these cases. You need to showcase your work to the larger world. Okay, and this is where the Society of Fetal Medicine comes. This is the current executive of Society of Fetal Medicine, and it is their mandate that we have to promote young talent. We have to bring them at level with the international speakers so that the world knows what we are up to. So we have to nurture all this talent that we have here in every nook and corner of our country. We have beautiful cases, beautiful machines, people working so hard to get amazing cases. So what are we doing? One, we are doing a weekly quiz in which you can submit your cases. We post them on our SFM channel, on YouTube, on Facebook, on Instagram, Twitter, which is now X. And this has got tremendous response. We have international audience. In fact, some of the cases they have received 300,000 plus views, lots of comments, and it's doing quite well. So do send your excellent cases to us. We will see whether we can post them as a quiz uh, in our weekly SFM quiz. And this is the second initiative that I'm happy that I'm a part of. This is the Young Guns webinar. We did one webinar last month, and this is we are doing with Pune chapter. And I hope that we keep on continuing these Young Guns webinars on a monthly basis, chapter wise, so that every young presenter who wants to present their case, who wants to showcase their work, they are able to present their work in these webinars. What do they get in return? They get in return expert mentorship. They get to know, discuss their cases. They get to know how to present their cases well. And if there are any shortcomings in their presentation, slides or cases, we are here to rectify them. And what they also get, they get a acclaim on the national level. They get applause from people who are their peers. And this, I believe, it should make everybody jealous, this opportunity. So when you share your cases, actually what you do is you are opening your minds and the minds of others to new ideas, new concepts, new ways of gaining knowledge. And you are also inspiring someone somewhere who's sitting in some part of the country to do and match up with your good work. And this is how we are going to reach every corner of India and provide every fetus with an optimum outcome. So what you need to do is when you have a case and when you want to present, you contact your state chapter. If you do not know who to contact, go to the SFM website, and on the website on About Us, you will have the list of your chapter executive members, and you can call them or email them. And you can tell them that, yes, you want to present. Whenever the chapter's turn comes to host this webinar, you will be asked to present. Or you can contact us, or you can send your cases to sfmacademiccouncil@gmail.com. And these are the cases we will look at, and then we will try to post them as our Twitter quizzes. So this is how together we can make a difference, and this is how we will, increase the academic capability of fetal medicine in India. And in no time, from a young gun, you will become the top gun. Thank you so much.
Alok, will you introduce the young speakers now?
Varun is going to do that. Varun
Okay.
is the secretary of Pune chapter, and I think Chinmay also has to say a few words.
Oh,
Yeah.
yes, sir. So I'll go ahead. Thank you so much, Mohit sir, Alok sir, for giving Pune chapter this opportunity. And thanks to our mentor, Khurana sir, for creating all of this, and Varun for initiating this. So the topic given to me today was very interesting. Wisdom and young enthusiasm. Can they go hand in hand? And that really made me think because we always symbolize wisdom and enthusiasm, youth as yin and yang, isn't it? We feel youth is symbolized by energy, passion, and idealism, and wisdom is more about experience, patience, deeper understanding, knowing things, and ability to use that knowledge are two entirely different aspects. So, knowledge versus wisdom. And to make sound judgments based on knowledge, experience, and our EQ is what really wisdom is all about. And it, of course, involves we drawing onto our critical thinking, we being aware about ourselves and the circumstances, and our ability to foresee the consequences. Whereas youth is characterized by curiosity, enthusiasm, and an innate desire for change. It often lacks experience, but compensates with creativity and open-mindedness. And that is why this constant tussle, and it is generally widely believed that youth and wisdom, they cannot coexist. But what does the evidence suggest? We of course know of Joan of Arc or Mozart, and I come from the city where we had Shivrai, who at the age of 16, and Santan Naneshwar, who at the age of 21 did the best of their deeds, and they really passed away in very young ages. Does that really true hold to science? Absolutely. Let us talk more about our own science. How did we get here? Piezoelectricity was invented by Pierre Curie at the age of around 20, 21. and involved an obstetrician who was actively involved in Second World War, helped people develop sonars, and then uh, converted that knowledge when he was back from the battlefield into using it as an ultrasound for fetus. Purcell helped us create MRIs, and of course, the man who created this branch and took it to the level that it truly exists, Professor Kypros Nicolaides, uh, took it entirely to the different level with the help of ultrasound machines. All of them, you'll be surprised to know, started the biggest of their work in their 30s or even late 20s. And as we keep saying, more evolved you are, more dependent you are on your parents. By that logic, compared to say our politicians or our social workers, maybe these doctors were much more evolved because they took longer to get there, but they changed everything. And in that change, they made motherhood and childhood safer. Thus, the combination of young bloods, old souls, open hearts, and free minds will get us there, will get us that perfect yin and yang, which we always want to coexist with. As Alok sir was mentioning, right environment, exposure to challenges, and mentorship can help youth develop wisdom early. And thanks to our mentors here on the screen and all those SFM mentors who have created this building and this palace called Society of Fetal Medicine. Thanks to them, we can make our youth wiser. And I think Young Guns is all about that. So thank you, Alok sir, once again for giving us this opportunity. Over to Varun for the next proceedings.
Yeah, good evening all. So with Purana sir's and Mohit sir's permission, shall we proceed with the first young gun topic? Yeah, perfect. So Nitin sir, may I request you to please share your screen?
Am I audible?
Yes, you are.
Yes.
So the first presenter of today is Dr. Nitin Zadav. He's a consultant radiologist at KR Diagnostic Center in Pimpri Chinchwad, Moshi, and he has presented before in multiple state level and national conferences. He's going to present today on big things in little hearts. Over to you, Nitin sir.
Is my screen visible?
Yes, it is.
Can you see the video? Is it playing nicely?
Yeah, it is.
Yeah.
Yeah. Good evening, everyone. First of all, I would like to thank Society of Fetal Medicine for giving me this opportunity. Today, I will be presenting one case. The title of my presentation is Big Things in Little Heart. So here comes a case. A 30-year-old Gravida 4 patient came to me for NT scan. There was no consanguinity. She had one miscarriage, first trimester miscarriage. She was a known diabetic, and there was no other significant history. So this is a fairly decent NT scan image showing a normal nasal bone and NT. One subtle finding in this image is there is some fluid in the thoracic cavity, which is clearly seen in this image. There is a definitely significant amount of pericardial effusion on the scene per abdominal. You can see there is a significant amount of pericardial effusion. When I saw the pericardial effusion, first I thought it can be because of the baby might be in a state of hydrohospitalis. So I just thoroughly screened for the entire baby, entire fetus to see for the other signs of hydrops, but I couldn't find any other signs, like there were no ascites, there was no pleural effusion, there was no skin edema or something. So I thought it can be because of some cardiac pathology. So I tried to see for the heart in detail. So this is the scene of heart where you can see heart is absolutely looking normal. Both inlets are normal in size as well as both outlets are normal. So I got confused. I was not happy because I couldn't find out the cause of gross pericardial effusion. So that's why that I wanted to find out what can be the cause of this gross amount of pericardial effusion. So I just tried to focus on a fetal heart. I switched to the linear probe. These are the cine taken with the linear probe. And on this cine, I found one finding which can be the cause of this pericardial effusion. If you see here, there is a small, defined thin-walled cystic structure just adjacent to the left ventricle near the cardiac apex, and which is well seen in the next cine, zoomed up cine. I'll go back, sorry. So in the second scene, you can see. So I just try to focus on that part, whether it is showing some abnormality on a color Doppler, and I saw some amount of some kind of a shimmering at the base of this lesion. So I thought it can be either some kind of a cystic lesion, or it can be some kind of a ventricular outpouching, or ventricular aneurysm, or diverticulum. So I just uh, focused, zoomed up the image. I slowed down the speed. I just adjusted the PRF, and I could see there was a definite communication of that lesion with the left ventricular cavity, showing both the colors. It is showing both red as well as blue color, and indicating bidirectional flow. And it was confirmed on a spectral Doppler. Yes, it was showing bidirectional flow with PSV reaching up to 45 to 50 seconds per second. So now I was sure that I was dealing with some kind of a vascular thing, which is just abutting the left ventricle near the apex. So I went through the literature and I tried to find out what can be the cause. So the two most common differential for these kinds of lesion are ventricular aneurysm and ventricular diverticulums. So here are few points to differentiate between them. Ventricular aneurysms usually have thin walls, just like in our case, while diverticulum has normal myocardial walls with all the layers. Ventricular aneurysm usually have a synchronous contractility or no asynchronous contractility or no contractility, while diverticulum shows a synchronous contractility with the ventricle. Aneurysms has usually wide neck, while diverticulum shows narrow neck. So in our case, it showed thin wall, no contractility, and narrow neck. It was showing features of both aneurysm and diverticulum. So sometimes it is very difficult to differentiate between these two entities on imaging, but it doesn't matter. It will not change the outcome as well as a treatment protocol. So when I went through the literature, I found so many articles about the ventricular aneurysm and diverticulum. So many cases have been reported, but most of the cases have been reported in a pediatric or adult series. There are very few cases reported in an antenatal series also. The earliest gestational age at which ventricular outpouching is reported is at 13 weeks by Carls. Our case is at 13 weeks, 5 days. So I found one more article which is relevant with our case. So in this article, I found they studied 6 cases where there was a ventricular outpouching, and the baby and the fetus had a pericardial effusion. They followed up these cases till postnatal period, and all the cases had a favorable outcome. No fetus required any kind of a surgical intervention. So considering this paper, I thought the lesion in our case can resolve spontaneously. So I called the patient again at 16 weeks. Meanwhile, we got her a double marker test done, and it showed low risk for aneuploidies. So patient came again at 16 weeks of gestation, and as expected, the ventricular outpouching is almost completely disappeared. There is no jet of flow seen coming from the left ventricle into the outpouching. I tried to document on a power Doppler assay also, but I couldn't see the jet of flow extending from the left ventricle. And even on the grayscale image, the outpouching is barely visible, and the amount of pericardial effusion is definitely decreased as compared to previous scan. So I just wanted to focus on the evolution of pericardial effusion. So I just called patient again after 2 weeks to see for the resolution of pericardial effusion. And in this scene, you can see the amount of pericardial effusion is significantly reduced as compared to previous scan. And on color Doppler, the ventricular outpouching completely disappeared. It did not recur, and there is no jet of flow from extending from the left ventricle. There is a mesocardia definitely, but it was seen since NT scan, and I thought the cause for the mesocardia can be due to the gross pericardial effusion. But This finding was resolving, but I tried to see for the rest of the fetus for any other system anomaly, and I found this. I had a doubt while looking for the perianal muscular complex. I couldn't see the PAMC comfortably, and the distal part of rectum was slightly dilated and echogenic, and I couldn't see the PAMC. So I had a doubt whether the baby is having anal low variety of anorectal malformation also. So I just wanted to be sure. So I called that patient again after 2 weeks, and as I suspected at 18 weeks scan, I was right. It was a low variety of anorectal malformation. You can see in the first scene, rectum, distal part of rectum is slightly dilated and echogenic, and it is not seen reaching up to the skin surface, indicating low variety of anorectal rectal malformation. And in the heart, mesocardia persisted. The pericardial effusion is significantly decreased, almost gone as compared to the previous scan. But one more finding popped up is dilatation of coronary sinus secondary to persistent left SVC. So one finding which I picked up at 13 weeks is almost completely resolving, while other findings were evolving. So I just wanted to be sure whether baby has other associated anomalies. So I thoroughly screened up for the other systems, and I found so many other associated anomalies in other system. Like in first scene, you can see lower lumbar vertebrae appears to be fused. Lower sacral vertebrae are not clearly visible, maybe not formed well. On one side there are 11 ribs, and on the other side there are 12 ribs. One kidney, which both kidneys were absolutely normal till 18 weeks, while one kidney evolved into multicystic dysplastic kidney at 20 weeks, and one foot also evolved into rocker bottom foot. So one finding completely resolved, while so many other subtle findings evolved at 20 weeks of gestation. So patient decided to discontinue the pregnancy, and this is the about us picture where we confirmed there was a imperforate anus, there was a rocker bottom foot. In spite of doing so detailed level of scanning and multiple scanning, I missed one finding on antenatal scan is abnormal genitalia. In this scene, in this image, you can see the genitalia is not typical for male as well as female. I went back again and I saw the scene. And if you see in this scene, the external genitalia is not typical for male and female. It is looking like a tulip. And in the internal genitalia, if you see here, the rectovesical space is very thin, indicating a male kind of a internal genitalia, but external genitalia is not typical of a phallus. Maybe it is a short phallus or it can be a hypospadias. So I missed this finding on antenatal scans. This was also very subtle finding. So finally, this at 20 weeks, there were multiple very subtle anomalies like spinal abnormality. Baby had a ventricular diverticulum with narrow neck. There was a rocker bottom foot. There was anal atresia. There was multicystic dysplastic kidney as well as abnormal genitalia. So to sum up my findings, baby had vertebral abnormalities, anorectal abnormalities, cardiac abnormalities, tracheoesophageal abnormality. I was not sure, but there were no direct or indirect signs of tracheoesophageal abnormality, but that doesn't actually rules out the tracheoesophageal abnormalities. Most of the time, it can be seen on gross scans or postnatal scans. There was renal abnormality and there was a lib abnormality, confirming my diagnosis as a case of vectoral association. So just few theoretical points about vectoral. It is a anomaly which involves multiple system. The estimated incidence rate is about 1 in 10,000 to 1 in 40,000. Etiology is unknown, but likely due to the combination of genetic as well as environmental factors with disruption at the very early stage of embryogenesis. There are most of the cases are sporadic, but there are few familial cases also reported. As we all know, everybody must be knowing about the synonym vectoral. V stands for vertebral anomaly, then anorectal anomalies, cardiac defects, tracheoesophageal fistula, renal abnormalities, and lib abnormalities. Very close entity for this is Vater anomaly, where cardiac anomalies are not seen. And one more association is Vectoral H, where hydrocephalus is seen in addition to the vectoral anomalies. So take home message from my case is few fetal anomalies are very subtle and require extremely detailed evaluation to pick them up. Just like in our case, the ventricular outpouching and the communication, it took a lot of efforts to demonstrate. If you find one anomaly, we should thoroughly look for associated anomalies. Just like in my case, one There were so many anomalies, but all the abnormalities were very subtle. Only obvious finding was a multicystic dysplastic kidney. Rest of the abnormalities were very subtle. Few anomalies can resolve spontaneously, and many anomalies can evolve. So you should do your anomaly scan in very detail or thoroughly. Thank you very much. Over to you, Varun sir.
Yeah, that was a great presentation, Nitin sir. You've lived up to your expectation. Phenomenal imaging, phenomenal workup, and what a great follow-up. So many learnings from this one single case. Great, great job. So, may I invite the next speaker, Dr.
I'll stop sharing. Should I stop sharing
Yes,
now?
yes, sir, please.
Yeah.
So, may I invite our next speaker, Dr. Shrikant Chaudhary?
Yes, sir.
Dr. Shrikant is a radiologist who currently works in Pune. He's done his BCFRG and has got a first prize at Maharayat for his paper and a third prize at UltraFest. Over to you, Shrikant.
Yes. Thank you, sir. Good evening, everyone. I am Dr. Shrikant Chaudhary. My topic is a fetal umbilical portal venous system shunts. Multiple umbilical portal venous system anomalies are known in literature but are relatively rare in occurrence. These anomalies are usually diagnosed in second trimester during anomaly scans. We are presenting few umbilical portal venous system shunts encountered at our clinical setup. Just to revise anatomy in brief, umbilical vein takes a curvilinear intra-abdominal course and enters the liver and joins the left portal vein. The left portal vein then goes abruptly to right away from the stomach, creating a L-shaped segment, portal sinus. Portal sinus gives rise to ductus venosus, which along with the hepatic vein joins the IVC at the subdiaphragmatic vestibule. The main portal vein then joins the portal sinus, forming the right portal vein and its branches. The documentation of this X of same color is essential to rule out the intrahepatic portal venous system agenesis. There are multiple classification systems, but Achiron proposed the most comprehensive classification based on anatomical origin of the shunt into three types. Type 1, umbilical systemic shunt. Type 2, ductus venosus systemic shunt. Type 3, portosystemic shunts, subdivided into intrahepatic and extrahepatic. First case, ductus venosus agenesis. Here, we can see umbilical vein takes a curvilinear intra-abdominal course into the liver and ends blindly. No demonstrable intra or extrahepatic shunt was seen. Total 5 cases were diagnosed. 3 cases were isolated finding, of which 1 case developed severe IUGR in third trimester. 2 other cases were associated with cardiac anomalies and were terminated. In 1 case, amniocentesis was done, which came out to be normal. Next is a type 1 umbilical systemic shunt. Here, we can see umbilical vein, instead of taking a curvilinear intra-abdominal course, appears to go directly into right atrium. There is absent ductus venosus and intrahepatic portal venous system. Total 2 cases were diagnosed. Both cases were associated with hemivertebrae and were terminated. In this type, chances of cardiac failure and cardiomegaly are high. These are the diagrammatic representations of the same. Next is a type 2 ductus venosus systemic shunt. Here we can see umbilical vein coursing towards the mid portion of the IVC. At the junction, a DV-like structure with aliasing was noted, which is seen far away from the right atrium. Total 3 cases were diagnosed. All were DV shunting into IVC. 2 were isolated finding and the pregnancy was continued. Other case was associated with the tricuspid and pulmonary wall pathology and was terminated. This is the diagrammatic representation for the same. Next one is a type 3A intrahepatic portosystemic shunt. In this case, we can see a communicating vessel between portal vein to hepatic vein in sagittal section. On tracing the same communication, we found the communication between a left portal vein superior branch to the left hepatic vein. Here we can see a umbilical vein going into left portal vein. These are the three hepatic branches, and a communication was seen between left portal vein branch to the left hepatic vein. Next is a companion case for the type 3A shunt. Similarly, in this case, we can see umbilical vein joining the portal sinus, which then turns away from the stomach, giving rise to right portal vein branches. A communicating vessel can be seen shunting into the right hepatic vein. Next is a type 3B extrahepatic portosystemic shunt. In this case, we can see two aliasing structures. This is one and another one, this. The first one is a normal ductus venosus arising from the portal sinus. Here, we can see a splenic vein along with the superior mesenteric vein forming a main portal vein. This is IVC, this is aorta. A communication was seen between the main portal vein to the IVC. In this case, shunt was seen persistently till term with narrowing of the main portal vein. Postnatal surgical correction was done and now baby is doing well. Next is a companion case of extrahepatic portosystemic shunt. Similarly, in this prone baby, we can see two aliasing structures. One is a normal ductus venosus and another one is a shunt between the umbilical vein to the IVC. In this case, postnatal scan at 3 months of age showed persistent shunt with narrowing of the portal vein with no signs of hepatic failure. In cases of intra and extrahepatic shunts, spontaneous closure of the shunt is expected. If no spontaneous closure occurs, coiling or embolization of the shunt can be done postnatally. We have seen few cases of isolated intrahepatic shunts in healthy adults as an incidental finding. Next is a hepatic artery to portal sinus fistula. Here, mixing of arterial waveform was noted in all portal vein. So we deliberately searched for the cause and we found a communicating fistula between hepatic artery and the portal sinus. Here we can see aorta. This is a celiac artery and giving a hepatic artery, and a shunt was seen communicating between the normal ductus venosus, between the sinus, portal sinus and the hepatic artery. Follow-up after the 2-week scan showed fetal demise. Next is a hepatic artery to ductus venosus fistula. Similarly, in this case, mixing of the arterial waveform was noted in DV waveform, suggesting a fistula from ductus venosus to the hepatic artery. First diagnosed at a 15-week scan, it was large in size. Follow-up scans at 20 weeks and 28 weeks showed persistent fistula with reduction in size. Few key points. The presence of the intrahepatic portal venous system is a key to live birth, regardless of the type. Documentation of the X, which is the main portal vein to portal sinus anastomosis with the same color flow, is essential. Type 1 had a worse prognosis. These are more prone to cardiac decompensation as a cardiomegaly and hytrops. Type 3A showed highest incidence of IUGR and low birth weight. Type 2 and type 3B showed slight male predominance. Conclusion: diagnosis of various types of umbilical portal venous system anomalies can be made with detailed evaluation of the fetal umbilical portal venous system anatomy. Various outcomes depend upon the size, type of the shunt, and associated congenital anomalies. Significant number of cases were associated with other anomalies and fetal growth restriction in the last trimester. Most of these cases with isolated shunts showed favorable prognosis. Few studies have showed genetic abnormalities associated with these shunts, so genetic evaluation in these cases is advisable. Most common is a trisomy 21. Other are trisomy 18, 13, and Noonan syndrome. So when the vessels take the wrong turn, we should always look for the X. These are my references. Thank you. Over to you, sir.
Yeah, great presentation, Dr. Shrikant. You have a beautiful compilation of cases and also the follow-ups. This is a very vast topic, but you have managed to finish it in time and squeeze all the cases very nicely. Uh, you should make a paper of it and send it to our journal, that is Journal of Fetal
Yes,
Medicine.
sure,
So
sir.
try doing that, please. Okay.
Thank you, sir.
Great. So may I invite our next speaker, Dr. Amol Deshmukh, sir. Dr. Amol, you can share your screen. Dr. Amol Deshmukh is a radiologist, is trained at Thane Ultrasound Center and is currently working as a fetal medicine consultant at Umarji Mother and Child Care, and is known for his beautiful imaging. Over to you, Dr. Amol Deshmukh.
Thank you, sir. Myself, Dr. Amol Deshmukh, consultant radiologist at Umarji Hospital. Today's topic for my talk is whether CSP is really equivalent to the CC. So when we do fetal brain assessment, we have two strategies. The first one being basic fetal brain screening during routine anomaly scan with the axial imaging. And if something comes positive, we go for detailed neurosonogram on TVS scan. So in basic fetal brain screening, we have three axial views: transventricular view, transthalamic view, and transcerebellar view. When we go for neurosonogram, we have four coronal views. The first one being transfrontal view, in which we see interhemispheric fissure, frontal lobes. Second one is transcaudate view, where we see, it is one of the most important view, where we see frontal horns of the lateral ventricle, CSP, body of CC, and caudate nuclei. The third one is transthalamic view, where we see both thalami, third ventricle, sylvian fissure, and optic chiasma. And last one is transcerebellar view, where we see posterior fossa structures. Another views are sagittal and mid-sagittal view, in which in mid-sagittal view, we mostly see all midline structures like CC, in which we should see qualitative and quantitative analysis. Qualitative means we should see all four parts of the corpus callosum: rostrum, splenium, body, and genu. Vermis, midbrain, brainstem, pons, and medulla can be seen. So, as we all know, that embryological development of cavum septum pellucidum, that is CSP, and CC go hand in hand. We always see, in that relation, we always see three scenarios. The first one being, when we see normal CSP, it mostly corresponds to the normal corpus callosum. The second one, the absent CSP always correlated with the absent corpus callosum. And third one, where abnormal CSP means wide and small CSP can be associated with partial agenesis of the corpus callosum. So correct recognition of CSP is reassuring for the proper development of the central forebrain. But we are heavily relied on the CSP for evaluation of CC. Here we are going to discuss two cases which are deviated from these common scenarios. First case, in which 31-year-old female, non-consanguineous marriage, IVF conception with donor sperm, anomaly scan done elsewhere at 19 weeks reported as normal. During growth scan at 29 weeks, microcephaly in moderate ventricular megaly was seen. Patient came for review scan with us at 30 weeks. On axial fetal brain screening, we confirmed that microcephaly and severe ventricular megaly was there. Further, we saw CSP normally seen in coronal as well as axial views also. When we went for transvaginal neurosonogram, to surprise us, corpus callosum was not seen. So it was a complete agenesis of the corpus callosum despite of normal CSP. So here question arises whether normal CSP is really corresponding to the normal corpus callosum. In another case, we had 27-year-old female, G3P1L1, anomaly scan at 19 weeks was normal. Recently, previous child been diagnosed with capillary spots Mother also had several cutaneous neurofibromatosis. They all went for the genetic testing. Amniocentesis for present pregnancy was also done. It came positive for NF1 gene for neurofibromatosis 1. We did review scan at 28 weeks. On axial brain screening, we found that CSP was not visualized. On neurosonogram, however, corpus callosum was absolutely normal. As we all know that isolated obliterated CSP in second and third trimester can be normal physiological finding. But this is a CSP of the same patient at 19 weeks and CSP at 28 weeks. So, but our question still there, that whether normal CSP is really equivalent to the normal corpus callosum. So we will go back to our strategy where we do fetal brain assessment. So basic fetal brain screening and neurosonogram, there is nothing in between. So we really need to think that all three axial images are really enough for basic brain screening, as it is imbalancing between neurosonogram and basic screening. So as Alok sir that they pointed out, so we should go for extended brain screening. So in which anyway, this mid-sagittal view, every day, every routines can be do for mid-facial profile. So we should see that midline structures like corpus callosum vermis in same view. And we also should see that oblique transventricular view in which which can eliminate our near field artifact which we see in routine transventricular view. That is a take-home message from my side. We should see two extra views in extended neurosonogram. Thank you, sir.
Beautiful presentation, Dr. Amol. You have shown us how important a basic structure like CSP is. We are really mesmerized by that. And we all know now that CSP, despite of being a basic structure, has got a huge meaning and huge implications associated with its abnormalities. And so to learn these basic things, I request everyone to register for our national event, that is BasicOn, which is going to happen in the first week of August. And now may I request our Director of Operations, Mr. Vishal Mittal, to share the trade partner video. So welcome back again. Now may I invite Dr. Mayuri Dikshit. She's a consultant obstetrician and trained into fetal medicine. She works at her own clinic in Satara, and she's going to present her topic. So over to you, Dr. Mayuri.
Yes, sir. Thank you, sir. And good evening, everyone. At the outset, I would like to thank Society of Fetal Medicine for giving me the opportunity to present in front of esteemed national faculty. My special thanks to Dr. Ashok Khurana sir for giving us this platform and for his expert mentorship. I am Dr. Mayuri Dikshit from Satara district. Today, I will be presenting a case of 30 years old female non-consanguineously married with AB positive blood group, gravida 2, one abortion done in view of retinoic acid consumption. This was a natural conception with NT-scan reported normal. First trimester combined screening was low risk. On anomaly scan, the fetal growth was corresponding to 20 to 21 weeks of gestation. A echogenic region measuring 11 by 11 was seen close to the left chordothalamic groove. It was extending along the floor of the frontal horn of left lateral ventricle. There was also prominent left lateral ventricle. Hence, extended fetal brain sonography was performed. This is transcaudate plane. The echogenic region is seen here close to the left chordothalamic groove. This is parasagittal view. The echogenic region seen here along the floor of the frontal horn. This lesion did not take color after putting power Doppler slow flow mode. The corpus callosum and vermis was seen well. By now, we all might have got the diagnosis. The couple went for fetal MRI. The MRI was done at Bharati Vidyapit, Pune, thanks to Dr. Priscilla Joshi ma'am. MRI showed an area of altered signal intensity measuring 11 by 11 mm in the region of left caudothalamic groove, causing mild mass effect on the left frontal horn. So, what is the diagnosis? It's germinal matrix hemorrhage. The counseling of the couple was done that germinal matrix hemorrhage can be associated with chromosomal or monogenic disorders, torch infections, maternal or fetal coagulopathy. The definitive test to diagnose the chromosomal or genetic disorder is amniocentesis at this stage with genetic testing with QF-PCR, whole exome sequencing. Also, we have to check for toxoplasmosis and CMV-PCR, and we have to do the DNA storage. Also, we suggested them pediatric neurologist opinion and to rescan after 4 weeks for the progression of the lesion and for any signs of hydrocephalus. Also, maternal testing for coagulopathies was advised. The couple decided to terminate the pregnancy. They sent the fetus for autopsy and DNA storage was done for them. On fetal autopsy, hemorrhage was seen at the caudothalamic groove, which was in the frontal horn, near the frontal horn of left lateral ventricle in front of the choroid plexus. Also, there was hematoma seen on the liver surfaces. Also, there was hemorrhage on the mesentery and the bowel surface. Couple has not yet opted for any genetic testing or any maternal testing for coagulopathy. So, we will briefly go through the anatomy of the germinal matrix. The germinal matrix is formed in the periventricular region early during the embryogenesis from 8 to 28 weeks of gestation. So, we do not get germinal matrix in the mature newborns. This is the lateral ventricle, and lateral to the lateral ventricle, we get to see the germinal matrix. It is located lateral to the lateral ventricle within the brain matter in the caudothalamic groove. So this is caudate nucleus and this is thalamus, and here in this groove, the germinal matrix is present. From here, all the cells migrate peripherally to form the brain, hence forming the gray matter. Thus, it plays a crucial role in the development of brain structure and neural slits. It is densely cellular and not surprisingly also densely vascular, which makes it vulnerable to hemorrhage. Germinal matrix hemorrhage is an important cause of infant morbidity and mortality, causing neurodevelopmental disabilities, including developmental delay, motor impairment, epilepsy, or fetal or neonatal death. The predisposing factors might be maternal, fetal, or pregnancy related. Maternal factors are alloimmune thrombocytopenia, idiopathic thrombocytopenic purpura, Wolff-Wiener disease, drugs like warfarin and antipyretic. So we have to get the history from the mother whether she is on any drugs like warfarin, thrombophilia, vitamin K deficiency, or trauma. The fetal factors might be fetal coagulopathies, anemia, thrombocythemia, inborn errors of metabolism, gene mutations associated with familial intraparenchymal hemorrhage, or infections. Pregnancy-related complications like perinatal hypoxia and asphyxia, placental abruption, preeclampsia, chorioamnionitis, or complications of monochorionic twin gestation as TTTS and co-twin demise. These risk factors are closely linked to the pathogenesis of germinal matrix hemorrhage. Besides the coagulopathy, which explains for itself as a risk factor for germinal matrix hemorrhage, what can we think might be the common cause in above listed factors? So each factor in above mentioned list causes increase or fluctuation in the cerebral blood flow, thus causing hemorrhage in the germinal matrix, which is very vulnerable. There is a papillae grading system for germinal matrix hemorrhage. Grade 1 is hemorrhage confined to the germinal matrix. Grade 2 is intraventricular extension involving less than 50% of its volume. Grade 3 is intraventricular extension involving more than 50% of its volume or associated with ventriculomegaly. Grade 4 is hemorrhage into the brain parenchyma. The phases of hemorrhage is like any other hemorrhage in the body. The first phase is acute phase, which lasts for 3 to 8 days. The lesion is hyperechoic in this phase. In the following 2 weeks in the subacute phase, the lesion becomes hypoechoic in the center and is surrounded by a hyperechoic rim. Eventually, in the chronic phase, the lesion retracts and is sharply demarcated with uniformly forming hypoechoic lesion forming porencephalic cyst. So, I will conclude with the following points. Fetal intraventricular hemorrhage is an important cause of infant morbidity and mortality. Intraventricular hemorrhage results from the bleeding of a germinal matrix. We have to think of this disorder when ultrasound findings are ventricular dilatation or intraventricular hyperechoic masses. A genetic disorder must also to be considered. The identification of genetic causes can guide the counseling process with respect to the recurrence risk and future pregnancy management. Thank you.
Yeah, wonderful presentation, Dr. Mayuri. Single case of germinal matrix hemorrhage. You have worked up very well. You've done an MR, you did an autopsy, and that was a fabulous case. And also the theory part that you have covered, really great presentation. So may I invite the last speaker of tonight, Dr. Sneha Mote from Kolhapur. She is a radiologist and a fetal medicine consultant working in her own clinic, that is Adi Center of Fetal Medicine. Dr. Sneha, you can please share your screen.
Yes, sir. Good evening, everyone. So I have one case presentation today. Topic for the case is pushed heart suspecting the invisible. When I was working at Pune, we had one patient. She was 25-year-old, gravida, came for routine first trimester screening at our center. There was no significant medical or family history. She had third-degree consanguineous marriage. So we started our scan with taking fetal heart rate, and on this axial 4-chamber view, we noticed one finding, that is heart was little bit pushed towards the right side with mild left-sided pleural effusion. On longitudinal section, we also found the left-sided pleural effusion, same as in we could see in sagittal section also. So our findings were left-sided pleural effusion with mild displacement of the heart towards the right side. When we find one finding, we always search for the other abnormality. On this sagittal view for the ductus venosus, we can suspect ductus venosus is present, but it is not the ductus venosus. It is just the joining of the umbilical vein with the hepatic veins. Normally, DV is seen as an aliasing part. Here we can see aliasing DV in normal patient. So our diagnosis was non-visualization of the DV, that is DV agenesis. Other systems were absolutely fine. Normal 4-chamber heart was there and he was normal. So in conclusion, we had 3 findings: mild pleural effusion on left side with mild mediastinal shift towards the right side with DV agenesis. We suspected chromosomal and mainly monogenic etiology in view of consanguinity, and we advised early anomaly scan and invasive testing. Patient came for early anomaly scan at around 17 weeks. Here again on 4-chamber axial view, we can see heart is pushed towards the right side with persistent left-sided pleural effusion, and there was something in the left hemithorax. On sagittal video, here we can see there is herniation of the stomach and little bit of intestines into the left hemithorax, and right hemithorax was absolutely fine. So our findings were left-sided pleural effusion with stomach in the hemithorax and extraposition of the heart. Here we can see intact right hemidiaphragm and there is defect in the left hemidiaphragm on posterior aspect with herniation of the stomach and intestines into it. So diagnosis was congenital diaphragmatic hernia. Other systems were absolutely fine. There was minor finding of persistent left SVC. Here we can see 4 vessels. Deviogenesis was there, which we diagnosed in NT scan. Umbilical vein was directly ending into the portal sinus. No obvious shunt was seen. So for prognostication, we calculated LHR, which is lung area to head circumference ratio. We calculate the contralateral lung by tracing method or by longest diameter method. We just have to put the values in perinatology.com. If the value is less than 1 or less than 1, it has poor prognosis and may be the candidates for prenatal intervention. If it is between 1 and 1.4, ECMO is often needed. If it is more than 1.4, the prognosis is better. In our case, LHR was 0.83, which suggested poor prognosis. QLI means quantitative lung index is calculated by this formula. 50th centile for the 16 to 32 weeks fetuses is 1. If it is less than 0.6, it is called small lung. In our case, QLI was 0.6, which was borderline for the small lung. In summary, we had 3 findings of congenital diaphragmatic hernia with mid-aspiral shift, deviogenesis, and bilateral SVC. No other major anomaly was there. So we suspected chromosomal and monogenic etiology as before. Advised invasive testing with fish microarray and whole exome sequencing in vivo consanguinity, and close follow-up for the lung hypoplasia, development of portal system, and evolving coarctation because of PLSVC. After counseling, patient opted for the termination of pregnancy. Genetic testing of the abortus was done, and luckily we can do the autopsy of the abortus. Genetic testing of the abortus showed no pathogenic or likely pathogenic variant, which was absolutely normal. On autopsy, we can see there was herniation of the stomach into the left hemidiaphragm, and we confirmed our finding. Congenital diaphragmatic hernia is nothing but the herniation of the viscera, abdominal viscera into the thorax. It can be bowel, stomach, or liver. Left-sided are more common than the right-sided. Why we worry much about this? Because it leads to respiratory abnormalities like pulmonary hypoplasia and pulmonary hypertension. It has associations with other chromosomal defects in 20% of cases, commonly trisomy 18 or 13, occasionally 12p, tetrasomy 12p, Thalasser-Killian syndrome. Genetic syndromes, most common is Fryns syndrome, and defects in other system, more commonly in cardiac system and other craniofacial system. Embryologically, diaphragm is mainly formed by 4 components. First is septum transversum. Second is paired pleuroperitoneal membranes. Third is dorsal mesentery of esophagus. And fourth is mesoderm of the body wall. This is the septum transversum, which divides the peritoneal cavity from the pericardial cavity. Dorsal mesentery of the esophagus forms the pleura of the diaphragm, and mesoderm of lateral body walls have little bit role in early diaphragmatic development. For us, paired pleuroperitoneal membranes gives a more importance because they have major role in early diaphragmatic development. If there is defect in the pleuroperitoneal canals fusion, which occurs at 8 weeks, congenital diaphragmatic hernia occurs. If there is defect in the fusion of pleuroperitoneal canals at 8 weeks, till 12 weeks, it may not manifest. Up to 12 weeks, there is physiological herniation, means there is bulging of the intestine into the umbilical cord insertion, which disappears by 12 weeks. And after that, the intra-abdominal pressure increases and forces abdominal viscera to migrate through the defect. So the CDH, the defect in the CDH can be present since 8 weeks, but it can present at any gestational age after that. So my take-home message is hernia may be there since the development of the diaphragm, but it may not manifest since the beginning.
Well, I will sleep.
Thank you.
I think this is just excellent. All of you Dr. Nitin Zadav, Dr. Shrikant, Dr. Amol, Dr. Mayuri, Dr. Sneha. I mean, all of you being radiologists, I just want to say one thing. You've broken the deep-rooted shackles that we've lived through, that the radiologist just diagnoses and leaves it there. You venture into counseling, you venture into genetics, and it talks a lot about your passion and dedication, not only to your subject, but even to your patients. This is the ethos of Society of Fetal Medicine, that we make every fetus count, right from not allowing to terminate and wanting this pregnancy to continue to see how things develop before we actually justify termination. But in that process, reading it up, knowing what to expect next, and counseling the patients as well as obstetrician is an integral part of fetal medicine today. So I'm extremely proud of all of you by the way you have presented. Your take-home messages were very crisp, but most of all, your images were very good. And you spoke well, your labeling was right, your follow-up was crisp, and most of you did go into genetics. So that's the right way. I can't tell you how many people you would have inspired today. Congratulations to the entire team. I thank Dr. Chinmay and Dr. Varun for taking this, taking these youngsters in your fold. And I do expect all of these speakers are SFM members. If you're not, please become members. You are the future torchbearers of Society of Fetal Medicine. We would want to work with you. Please become members if you're not. And thank you, Dr. Alok, for mentoring this group of young talent. Thank you so much. I really enjoyed all cases. It was a good learning for most of the speakers. You can see that there are almost 220 registrants logged in all throughout. Congratulations. Well done. Really proud of you all.
Yeah, Alok sir.
May I ask Rana sir to give his comments if he's available?
Thank you very much. It is so fulfilling. And I'm sure Dr. Santosh Sabnis feels like this about the Pune chapter as well, the Greater Pune chapter, which he initiated a few years ago. I'm sure he never expected that this would be the kind of response we would get in such a short time. Of course, it's taken a lot of teamwork. It's taken a lot of initiative by Chinmay to inspire so many people in the Greater Pune area. And Varun to have sat and inspired all these kids to put their work together. I can't call them kids anymore. They're certainly the leaders of today, not the leaders just of tomorrow or day after tomorrow. And it gives me a very deep sense of fulfillment when I see a program like this, because then we know that the future of the women of this country is really in safe hands. Congratulations to the whole team for putting this together. And I think this idea of having every single one of our regional chapters do this is going to be terrific. And each one of them can write in to the central office, and then we can work out when they're going to have their presentations. But thank you indeed. And I'm looking forward now to the question and answer session as well.
So I feel like a, proud mama hen. My, my little eggs have all hatched and now they are flying away. So obviously, some of these are very seasoned presenters like Nitin and even Amol presents, but some of them they were first time presenters today. And I think they've done an excellent job, covered multiple systems and lots of learning. So Varun, let's go ahead and take the questions. And
Yes,
I
sir.
think we should invite the speakers to address those questions, and maybe we'll pitch in with the discussions.
Certainly, sir.
So there are a few questions in the chat box. So the first question is, Nitin, Varun, please.
Yeah, so the first question is to Dr. Nitin sir. How early can PAMC be visualized, and after which gestational age anorectal malformation diagnosis can be given? Dr. Nitin, sir?
Yeah, am I audible?
Yes, you are.
Traditionally, we say that perianal muscular complex is comfortably seen after 22 weeks of gestation in almost all cases. So, whenever it is an isolated findings with no associated signs or there is no bowel dilatation, we can safely diagnose anorectal malformation after 22 weeks of gestation. But earlier, you can see PMC at earlier scans also. The earliest reported case is at 12 weeks, but definitely there must be some associated signs like a rectal dilatation, or just like in our case, just like in my case, there were other associated signs. So I could comfortably diagnose that as a case of anorectal malformation. So anorectal PAMC can be comfortably seen as early as 12 to 13 weeks if you're doing your NT scan with a transvaginal probe or using a higher frequency probe. But the level of confidence to diagnose it as a PMC will depend upon the other associated findings. If it is a very isolated finding without any other signs like rectum dilatation or no other associated anomalies, don't be in a hurry to call it as an anorectal malformation immediately. You can now, according to the new amendments in the MTP law, we have a time till 24 weeks of gestation. So we don't need to be a hurry in a doubtful cases. We can definitely do a follow-up scan till 22, 23 weeks if there are no associated signs. But if there are associated signs like other vertebral anomalies, like dilatation of rectum or something, you can comfortably call it as anorectal malformation as early as possible.
So on the same line, Nitin sir, you have one more question. How to diagnose low variety of anorectal malformation in ultrasound? How did you do it in the first case?
Actually, it is just a presumed diagnosis on antenatal scan. I do not find any nomograms for the measurement of rectal pouch to the skin surface. But there are various measurements available on a postnatal scans like live bus. In one paper, I found that if the distance of rectal pouch from the skin surface is more than 12 millimeter, it is called as a high variety. But on antenatal scan, roughly, if the rectum is not seen reaching below the level of bladder base, which is actually the level of levator ani, we can call it as a low variety. If it is not reaching up to the bladder base, we can call it as a high variety. But that will be just a presumed diagnosis. Actual diagnosis will depend on the postnatal scans.
Very well, sir. Thank you, sir.
Yes. Alok, sir, do you want to add anything to this?
No, this is perfectly said. It is difficult to distinguish low from high type. The other thing is in low type, it's difficult because sometimes the perianal muscular complex can be visualized, not sometimes very distinctly, but it can be visible. So that is why we end up missing so many low type of anorectal malformations. The high type is relatively easy because you see the rectal dilatation and you see the absence of the perianal muscular complex. But low type is definitely very difficult.
Right. So the next question is how to calculate below 3 standard deviation for microcephaly. Is there any formula? Does machine calculates it automatically? I think this is for Dr. Amol.
Yeah. So actually machine doesn't calculate it for ourselves. 3 standard deviation means 99.7% of the data falls within the normal range. So practically below first centile is below third standard deviation. And for microcephaly, so below first centile plus HC to AC ratio falling below third centile, we call it microcephaly.
Actually, it is better to use the tables given by Chervenak and Dr. Leibovitz and then use those calculations, because standard deviation does not actually correlate that much with percentiles. So in fact, you go to perinatology.com, they have a calculator in which you put in the head circumference in millimeters and just press the button. They will use the Chervenak formula and tell us whether this is microcephaly or not, or it is suspected to be microcephaly or not. So
Leibovitz has its own
yes,
he's got a calculator which you can download and keep it with you. And so in fact, they've got all the three. They've
Yes.
got Shervanach, they've got Intergrowth as well as Lebowitz own, the
Lebowitz.
Israeli this thing. And it also tells you what is, or exactly at what standard deviation it is falling in.
Yeah. Also, Dr. Dipali, -3 standard deviation, we consider it as microcephaly, but then it is not that straightforward. There is a paper by Professor Malinger, sir, in which he has described that half of the prenatally diagnosed microcephalies turned out to be normal at birth. So he has added one more thing to it, that is the foramen magnum to cortex distance. And if you incorporate all these things, then your sensitivity and specificity for diagnosis of microcephaly increases. This calculator is also freely available in his paper on microcephaly. So shall we move ahead with the next question, Alok sir?
Yes, please. Yes.
CSP ratio 1.4 and CSP was triangular in width, was 10 mm, 5 mm normal for that gestational age. CC vermis were normal. One side ventricle at 22 weeks is 9.2 millimeters. Can the counseling be done as good prognosis cause of normal corpus callosum? Dr. Amol sir.
Yeah, so CSP ratio means 1.4 means length is more than width. So, and triangular shape is also normal. So in that case, we can call it normal CSP with slight variation. CC vermis on biometry and qualitative analysis are normal. One side of ventricle 9.2 mm, which it is not fitting into the ventriculomegaly criteria, but we should see for the sugars. If sugars are high, GDM, so we can cut down sugars and we can reveal after 3-4 weeks. And this normal CC, we can say that this is a good prognosis.
Correct. The essence here is that we need to follow up this case, and just on the basis of a few findings, we cannot really say that this is going to be having a good prognosis or not. Because if you do a transvaginal neurosonogram, you may find some more small lesion which will change the prognosis, you change the diagnosis. So first do a good neurosonogram and do a follow-up after 4 weeks and see whether the ventriculomegaly, it progresses to ventriculomegaly or not. But if it remains stable, it improves, then of course we'll veer towards having this baby a good prognosis.
So next question is head circumference maintained at 5th centile at 20 weeks and 24 weeks. Corpus callosum and vermis both corresponding to 23 weeks. Any measures to be taken apart from follow-up?
Really specific queries. So as long as everything is within normal ranges, then we maybe worry a little because they are on the lower side of normal range. But if it is maintained, then I would not worry too much. I will simply follow these cases up and see where things are heading. Very important to look for other systems, because if you find something else in other systems, that obviously will change everything and the need for genetics, etc. But as of now, because if other cranial structures are normal, the head circumference is growing, then I will not worry too much. But if it starts dipping down, which it can, after, because this is just second trimester, but most of the time the microcephaly, it starts developing in the third trimester. So that is the time when we need to watch out the growth of the fetal head.
The CC length sometimes can be a little deceptive. So you need to look at the morphology of the corpus callosum, whether you're able to see all the parts or not. So if you're seeing a good rostrum, genu, body, and the splenium, in this kind of a scenario, I don't think this could be a constitutionally overall a small head. Look at the parents' head and in the family. All these factors you need to take into consideration, but don't label it as microcephaly with just the head circumference at the 5th centile. Because the moment you label it as microcephaly, the counseling and everything changes drastically, and unnecessarily this fetus may get terminated for no rhyme and reason.
Absolutely.
So next question is, with pleural effusion, do we still need LHR to prognosticate?
Pleural effusion itself suggests, I think, large defect because of which there is lymphatic drainage abnormality and there is effusion. But for prognostication of the contralateral lung and the hypoplasia of that lung, we need to calculate the LHR and we need to know, do the fetus is requiring intervention or ECMO after birth. In many cases of pleural effusion, babies do require ECMO after birth, but there is, we have to prognosticate LHR to know the status of the contralateral lung. Ipsilateral lung is already into the hypertension or compression, which is causing lymphatic drainage obstruction because of the large defect.
Bimal sir, your comments on this? Unmute, sir.
We've already landed up in a situation where there, pleural effusion is there. That itself actually is making the prognosis relatively poor. But yes, definitely, yeah, we given LHR as a quantification because if you want to follow this up also, it helps how it is progressing further. But presence of pleural effusion definitely is already making it a little, the prognosis is definitely going down here.
Dr. Sneha, what was the course of SMA in your case?
SMA was normal, sir, in my case.
Okay.
So it is not unusual for SMA to be normal in
Normal,
cases
yes.
in which there is only small quantity of bowel that is herniated up. If only there's a large CDH and then a lot of bowel has herniated, that's only the mesentery herniates too, and then we will see the upturn of the SMA. So not a reliable sign, SMA, if somebody is using only SMA as a sign for CDH. So the mediastinal shift is generally the first indicator that something is wrong.
Abnormal bowel dilatation measurements.
There are few nomograms available for the expected diameter of small and large bowel at gestational age, but those are rough measurements. A decent, measurement at which we can comfortably call it as dilated small bowel loop is 6 to 7 millimeters. Above that, the small bowel will be definitely dilated. And for large bowel loops, measurement above 22 millimeter in third trimester should be called as a dilated bowel loop. But it is a subjective thing. In many cases, we need to do a follow-up scan because sometimes the bowel dilatation can be a transient thing, and it can go off on subsequent scans. So roughly 6 to 7 millimeter for small bowel loops and more than 20 to 20 millimeters for a large bowel loop should be considered as a dilatation, bowel dilatation. Alok sir, your comments?
Yeah, the nomograms are there, but 7 mm is a reasonable cutoff. But make sure that you see a long segment of bowel that is dilated. At least it should be 15 millimeters or so. Then only we can say that it's a dilated bowel. And all these become actually very tricky when we reach third trimester and we start seeing the dilatation of the large bowel, which is filled with meconium, and that usually some people they misinterpret, but that is going to be at the periphery of the abdomen, whereas if you're looking at the small bowel, that's going to be in the center, and that's when we will look for bowel obstruction signs.
Few cases will have benign findings of prominent rectosigmoid at 20 weeks and PAMC not well visualized. When isolated findings, does invasive testing is recommended?
I will expect Varun sir to answer this question.
So, see, 20 weeks PMC not visualized. The paper, the people who have come up with this paper, they themselves have said that in 100% of the time they were able to demonstrate the PMC only after 22 weeks. And now with the new law coming in of 24 weeks, I do not see any hurry to label a normal fetus as an imperforate anus. So we can simply call the fetus again at 22 weeks and see if the target sign is seen or not seen. And if you are well versed with doing TVS, then I'm sure that at 20 weeks you can decently, I mean, you can very well document PAMC and can rule out high anorectal malformation or not. And if even after 22 weeks I'm not sure about the target sign, and if I have other ancillary findings like dilated bowel loops, then maybe I'll counsel them in terms of anorectal malformation. And yes, as we all know, if there is a structural abnormality, invasive testing has to be recommended.
Purana sir many times has a different opinion about target sign. So would you like to elaborate, sir?
You know, I personally feel that machine settings and where you look for a target sign makes a lot of difference. And when you get a bias with other findings, you tend to go ahead and say, okay, I don't see the target sign. And I know for sure that if we are honest with ourselves, most of us will miss about just about everything, even up to 20 weeks. There is no doubt that many of us will miss this because if you're just a little higher up in that particular pelvic plane, you're going to be able to mistake an anorectal junction for a target sign. And it's a question of a bias. So I'm never in favor of the famous target sign for low anorectal malformations. I just think that we happened to have once upon a time stumbled upon this information, and so often we've been proven wrong. Then we found completely normal anal canal and rectum. And the other way around, we were absolutely convinced that we were seeing everything nicely and there was absolutely no anal canal. So the problem is that the anatomy between the rectum and the anus is in such a tiny zone that you can easily make mistakes. And so when we come up with these and when push comes to shove in the consumer forum, we'll all be in trouble if we insist that we're picking it up so many % of the times. So let's face facts and say, look, in the real world, this is a difficult sign to go by. And if you happen to pick it up and you have ancillary signs, fine. But otherwise, this is not an easy diagnosis to make. And certainly not a part of the anomaly scan protocol.
That is true.
Yes.
Ashok doesn't mention it in the protocol at all.
No, there are absolutely no protocol anywhere in the world that
Yes,
mentions
no
it.
protocol.
Yes, it is our enthusiasm in our part of the world to do really excellent work that does this, and a complete sacrifice of our own personal time that makes us do these things, which is beautiful for the patient, but does not necessarily work in our favor all the time.
Because then we have the recent papers, one of the recent papers said that you could trace the rectum to the anus to the skin. So it does take a lot of excellence, technical excellence, and the baby has to be in the correct position for you to able to do that. So
Yes.
not always possible in every case.
No, certainly not. And with our average patient load, there is no question of being able to trace all of this unless you're working late into the night.
True.
Yeah, thank you.
Yeah, Dr. Nabila has asked the question, how to diagnose anteriorly displaced rectum, any criteria?
I think she means anteriorly displaced anus.
Anus. Yeah.
I know of no such a
No idea
clinical
about
criteria.
this. I don't have any idea about this.
Nabila has stumped us all. In one of the cases, this is basically anogenital distance. You can measure the distance between the anus and the genitalia which you are seeing. And I believe there are some nomograms. I happen to have read them a few years back. But truly speaking, I have never, cared to see or look for this anogenital distance with PNDT breathing out down your neck, it's really not that easy to look at all these structures for so long a time.
Yeah. Also, you see, in imaging, in fetal imaging, we've all become such magicians that the expectation from our patient is that sooner or later we're going to have to pick up a little missing fingernail somewhere. And then they'll say, I don't want a child with an abnormal fingernail.
That is
Now, this is something you and me really have to be careful about. So if someone comes and says, why did you miss an anteriorly located anal canal? It's very simple. It is probably not of clinical consequence, which is something we don't seem to think about at all. We lose that perspective, that there has to be a clinical perspective of significant disease compromising the quality of life. Now, we don't answer these three conditions, then we're really not entitled to even talk about a particular sign. So therefore, we should not promise the world. And we know that, yes, you might be able to pick up some of these. Some of them might be associated with the so-called cloacal abnormality, the varieties of mild cloacal abnormalities. And therefore, really, if a patient happened to have asked you, why didn't you pick it up? Or a clinician told the patient, oh, they didn't pick it up, they're so good at picking up these, which is such a casual remark by somebody, but such a serious remark from a legal point of view. You really have to be careful about the magic that we promise.
Also, as a member of board, I would like to insist over here that maybe a mild cloacal abnormality may not be an indication for termination. So if the case comes our way after 24 weeks, many times we would say no.
True.
Last question. 8.1 mm rectosigmoid at 26 weeks. Normal.
I think we should go through the nomograms for respective gestational age. We may not be knowing all the values for gestational age. So when you feel that the some part of bowel is dilated, you can compare with the nomograms. And if you feel it is dilated, you can keep those patients on a surveillance if there is a further dilatation of that part of rectum. And obviously you should look for other associated signs if PAMC is not seen or any other associated anomalies. That can be a transient finding also. And if for me at 26 weeks 8.1, I think it is within the 95th percentile. It is within the normal range.
correct. And we gave a lot of leeway to the rectosigmoid junction because it distends a lot. It can empty out. It can do whatever it can. So I think I will not be worried too much about a little bit dilated rectosigmoid junction, even if it is up beyond 95th centile. More importantly now, because if let's say you suspect something, there's dilatation, you can use that finding to look at the perianal muscular complex and make sure it is there.
True. Also, there is so much redundancy of tissue there that you don't know whether you're measuring the lumen, whether you're measuring redundant wall, and the 8.9 can easily become a 9.6, and then you get stuck because then it becomes borderline. So the best thing is to give a range of 7.9 to 8.9 and say serial evaluation is requested.
I think we have covered all the questions.
Yes, entirely. And it's been a fabulous discussion and fabulous presentations.
So, closing remarks, Varun?
Yes, thank you so much, Khurana sir, Mohit Shah sir, and Vimal sir, for giving this opportunity to us. It means really a lot to us. Thank you, Alok sir, for sparing the time, conducting a trial run, and helping all the young presenters. Thank you, my president, Dr. Chinmay Umarji sir, and of course our beloved Dr. Santosh Sabni sir, for being here. And most importantly, the presenters and the audience, which was around 235 people at one point of time, for joining in and cheering us up. Thank you a lot. That really means a lot to us.
Thank you, everyone, and we look forward to many more such programs. Good night.
Good night.
Good night, everyone. Thanks, Varun, for organizing.